Good morning, everyone. On behalf of Unit 1, Department of Internal Medicine, I welcome you all to today's chapter of Saturday Clinical Meeting. We have a learning case today. At the outset, it may seem very simple, but it will teach a lot of lessons as we go through today's case. The diagnosis of today's case is also very relevant to all of us, irrespective of specialties, because we have to deal with such diagnoses more often, not only in a professional life, but in our personal lives as well. So I would request Coordinator Rajesh to kindly proceed with the case presentation.
My patient, a 41-year-old female, resident of Satara, Maharashtra, informant self, reliability good, presented with complaints of weight loss for 1 year duration, paresthesia involving both her lower limbs for 3 months duration. She was apparently asymptomatic 1 year back when she noticed that she had gradual weight loss for the past 1 year. She had lost around 20 kgs, that she was around 52 kgs, which now she has become 32 kgs in the last 1 year. It is not associated with loss of appetite. However, it was associated with increased thirst and urinary frequency.
Can you help us causes of weight loss with preserved appetite or increased appetite? Can you provide?
Sir, the causes like hyperthyroidism or diabetes mellitus or any psychological disorders like depression or eating disorders or malabsorption disorders.
Okay. So broadly, we can say that uncontrolled diabetes, thyrotoxicosis, and malabsorption can present with weight loss with preserved appetite. Yes, please sit.
So as we can see that this is a picture of the same patient. On the right hand side, we can see that it is 1 year ago, and presently she has presented with the picture on your left side. We can see that she is severely malnourished, cachectic, and we can see thinning of limbs with a loss of buccal pad of fat. She also gives history of pain and paresthesias involving both the lower limbs for 3 months duration. It was insidious in onset, gradually progressive, involving both the lower limbs, and she gives history that she has feeling of pins and needles in both her feet. However, there is no history of heat intolerance, excessive sweating, or tremors. No history of greasy stools, nausea, vomiting, headache, or altered sensorium. No history of fever or cough.
So, Dendra, can you analyze this negative history and tell us why we have taken this negative history?
Sir, heat intolerance to look for any thyrotoxicosis symptoms. Excessive sweating is also the tremors with thyrotoxicosis. And greasy stools, like when fat malabsorption will be there, and greasy stools will be there, sir.
How do you connect this negative history with the chief presenting complaints?
Sir, in pancreatic exocrine insufficiency, there will be greasy stools, sir. Like fat will not be absorbed and it will pass in the stools.
The patient also has certain osmotic symptoms?
Yes, sir. Nausea and...
So can endocrine disorders also present? Coexisting exocrine plus endocrine?
Yes, sir. Exocrine and...
Abnormality which can be there?
Yes, sir.
What is that called as?
Sir, in pancreatic diabetes, sir, it is both exocrine and endocrine will be affected.
Next, why vomiting, headache, nausea? Vomiting?
Sir, uncontrolled hyperglycemia causes ketosis, and it causes symptoms of nausea and vomiting.
Good. And just to complete the list, we made an attempt to rule out the infection.
The infection to acute.
Coming to the past history, my patient is a known case of diabetes mellitus since 2020. She's on oral anti-diabetic drugs. Her drug compliance is poor. She's lost to follow-up with no history of hypertension or pulmonary TB in the past. In family history, patient's mother and elder sister both are a diagnosed case of diabetes mellitus and are on oral drugs. In personal history, she consumes mixed diet with normal sleep pattern with normal bladder habit. In the socio-economic history, my patient belongs to a lower scale as per modified Kuppaswamy scale. She lives in a Pakka government scheme house. There is overcrowding present and there is poor social support from the husband. In obstetric and menstrual history, my patient is a P2L2 lady, both full-term normal delivery. Last childbirth was 8 years ago. There is a history of hyperglycemia present during pregnancy. However, there is no history of any treatment or any follow-up for that. Her cycles are 4 by 28 days, which are regular with normal flow.
Reddy, can you summarize, Dr. Reddy? Can you... Yes.
Sir, 41-year-old female presented with, who is a known case of diabetes mellitus, presented with a history of weight loss since 1 year and loose stools for 6 months duration.
So weight loss with reserved
Reserved
appetite,
appetite.
with osmotic symptoms and speaker suggestive of neuropathy of about 1 year's duration.
Duration.
What are the differential with this?
Sir, maybe due to uncontrolled hyperglycemia, diabetes.
So everything can be explained even by uncontrolled hypertension. Please sit. Raj. So, Akash, can you tell us what are the types of diabetes?
So the latest ADA classifies diabetes as type 1, type 2, other specific diabetes, and gestational diabetes mellitus. So type 1 can be further divided as immune mediated and idiopathic. Then we have type 2. The other specific are further divided as A, B, C, D, E, F, G. A is genetic mediated. Then C is pancreatic diabetes.
Please. So basically, whenever we refer to any diabetes management, we refer to American Diabetes Association guidance, and every year we have a supplement from ADA, and we have a 2025 supplement which is available. So when we refer to this is a broad heading under which we classify diabetes, and we have a type 1 which includes autoimmune mediated, which broadly includes type 1 diabetes, and we also have a latent onset. LADA is also a diabetes which is autoimmune mediated. So that is also part of this. And then we have a type 2 diabetes, which is but what is this? This is the non-autoimmune progressive loss of beta cell function. There is also beta cell function in the type 2 also, but it is present in the background of insulin resistance, obesity, and metabolic syndrome, and other specific type of diabetes is included in this third broad category, which include monogenic diabetes, which includes diabetes of exocrine pancreas, and certain drugs, chemicals, infection-related diabetes. And a gestational diabetes has been given an isolated group, which is the 4 under this AD. Prashant, can you, so now we have this patient. So can you help us in understanding or deciding which type of diabetes is present in this patient? Once we have understood these classifications are there according to AD.
So she has she has a history of gestational diabetes first. Then sir, secondly, sir, the age of presentation is after 35 years of age, sir. We have no history which says that she was being worked up for any other causes of diabetes like latent LADA or autoimmune causes, sir. So and there is also no history of her BMI abhi tak. We have not received the BMI. Initially, sir, she was looks like overweight. So age more than 35 and overweight, probably type 2 diabetes.
Please. So this is a very important scenario which we need to answer whenever we are encountering a patient of diabetes mellitus. So we can have a very endless list of types of diabetes, but when we deal adult patient in a common clinical practice, these are 3 kinds of diabetes which we try to differentiate: type 1 diabetes, type 2 diabetes, pancreatic diabetes. This is for all practical purposes. This is a 90% solution when we deal with the dilemma of classification. Why it is important to classify diabetes? Because that will decide our management strategies. So let's see what happens. So family history would be more common in the type 2 diabetes. The insulin resistant feature means obesity, metabolic syndrome, certain clinical markers of insulin resistance like acanthosis, nigricans, etc. can be present in the patient with type 2 diabetes. Obesity, metabolic syndrome is a feature of type 2 diabetes. Diabetic ketoacidosis, very important. So, Prashant, you would have brought out that in last 4 years, patient never had such episode of diabetic ketoacidosis according to the history. So, diabetic ketoacidosis is a feature of type 1 diabetes because there is absolute insulin deficiency, and these patients, in fact, first time present and to the pediatric OPD, the children present to pediatric OPD more often with a diabetic ketoacidosis. Autoimmune diseases is a feature of type 1 diabetes because it is autoimmune diseases, autoimmune thyroid diseases, celiac disease, vitiligo, etc. can be present in the the feature of type 1 diabetes. On the contrary, basically pain, abdomen, steatorrhea, malabsorption, etc. are the feature of the pancreatic diabetes. So we have a very limited information. If we have to, attack these clues in our patient, probably we get a more higher point for the pancreatic diabetes because our patient is probably a thinly built, but yes, Prashant was correct that earlier she had a weight was higher. We don't know the exact BMI, but then patient does not have any feature of diabetic ketoacidosis, the autoimmune diseases. So probably we will little, and she comes from low socioeconomic status, we'll go towards little pancreatic kind of diabetes. But let's see how the further details of the case tells us. Mr. Sridharan, please tell us, how do we diagnose diabetes?
Sir, as per the latest ADA guidelines, sir, the fasting blood sugar of more than or equal to 126 milligram or postprandial sugar of more than or equal to 200 milligram, with a HbA1c of more than or equal to 6.4, with random blood sugar of more than or equal to 200, with symptoms of diabetes is considered as a diagnosis of the diabetes.
So, Sridhar has told us four tests which please. So we have four tests which are used to diagnose diabetes. So any of these tests, whenever it is present, we can diagnose the patient as a diabetes mellitus. But it's not as simple, because when we go through this ADA guidance, it is exhaustive the chart. But it's important to remember that even a single test, whenever there's an ambiguity, the test has to be confirmed. Either we do a same test on different occasion. For example, if we have utilized fasting plasma glucose, we have to do a fasting plasma glucose at some certain other time, or we do two different tests in same occasion. For if I have an ambiguity, if I've done the HbA1c, I might as well go ahead and do the fasting plasma glucose. This is the guidance which comes from, and it's important to understand HbA1c, although it tells us a longer term glycemic control, but it has to be done according to the DCCT. The assay has to be standard to the DCCT. But the DCCT is Diabetes Control and Complication Trial. The assay which was used in this trial is a landmark trial which every one of you should be reading and knowing about, and it has to be certified according to the National Glycohemoglobin Standardization Program. So, do we have a biochemistry resident here? So, 75 gram OGPT. So, we would be doing it in a day-to-day practice. So, what are pre-procedure advice you give when the patient comes to you for the?
Sir, first of all, patient has to be prepared for the OGTT, sir. He should be having at least 3 days prior, he should be on the normal carbohydrate diet, and it should not be protein-rich diet, sir. And after 3 days, we will preferably calling the patient in the morning for his fasting blood.
So just hold on there. So pre-procedure advice correctly brought up by him is that we should be advising the patient not to restrict the carbohydrate. Patient at least should be consuming 150 gram of carbohydrate for 3 days prior to his OGTT. Why it is important? Because if you restrict his carbohydrate, then there will be falsely high glucose level he can get. And this is a very, very practical, because most of the patients in services, they come, sir, I'm fasting, I will not consume a carbohydrate for 3 to 4 days prior to my test, because I don't want my blood glucose to be coming to be higher. So it is very important information. Pre-procedure advice is important. So which kind of glucose you are using when you do this 75 gram OGTT?
Sir, 75 gram of anhydrous glucose dissolved in 250 to 300 ml of water to be consumed over 5 minutes. And generally anhydrous glucose is not present, then in that case, sir, 82 gram of monohydrous glucose we will be using. And after 2 hours, we will be taking the 75 gram OGTT samples, sir.
So please, thank you. Good. So basically, when we refer to the diagnosis, when we were discussing the diagnosis of diabetes, it was highlighted there that it was we should do the test by equivalent of 75 gram anhydrous glucose. But what is the situation? Anhydrous glucose is a hygroscopic, which is not stable in the normal circumstances. So what we do, we adapt and we use a normal glucon B, which is available. Most of the lab are using this, and this is what is it containing? It is containing a monohydrous glucose. So there has to be some kind of conversion factor which is there, as brought out of the resident biochemistry we use. The conversion factor is the 75 gram of anhydrous is equivalent to the 82.5 gram of glucose. And this is important because most of the lab and we would be knowing that we are not practicing this. So, is there any other biochemistry? So, what is the exact protocol of doing? So, any medicines are taken, but okay, please. So, what is the exact protocol of doing 75 gram?
After within 5 minutes of intake, so then the patient comes back after 2 hours.
So you do it fasting, the patient can come.
No, so first we do the fasting.
So how much fasting?
So 140.
No, so the patient has to be empty stomach.
Yes, sir. 8 hours. 8 hours of fasting.
How do you define fasting?
So fasting, there should not be any intake of food. That is, the first is minimum 150. What as sir has said. Yes, sir. And
So
then
no calorie intake.
no calorie intake, no intake of any black tea or caffeine, no smoking, no intense exercises. The patient should follow the regular routine that he has normal daily morning activities. So
then how do you?
is in the first the sample is taken.
How do you administer the?
So the glucose we have to put it in 300 ml of water, mix it, and the patient has to be encouraged to